I'm going to say good morning, and then we're pinch hitting.
Yeah,
right?
we are. It's great to be here.
Yeah.
We're looking forward to this session today. Hopefully we've got some good information for you. I'm going to start off with kind of some requirements, paint the picture a little bit of what transparency is, and how it's functioning today with the current requirements and then also the proposed ones. Then we're going to do a bit of a case study. Monica's going to come up and kind of share a bit about how Providence is working through transparency and specifically in with the charge master, and then we'll kind of close things out with some next steps.
Right.
So anything you want to add?
No,
before we
we're
get going?
going to talk about some of the steps that Providence has taken on this journey, and also feel free to raise a hand and ask us questions while we're going over some of the material.
Yeah, very informal.
Yeah.
So hopefully good discussion as we get going. So I'll start things out. And we'll get moving in. I was on my flight in, and I'm sitting next to a guy as we're getting ready to land into to Spokane, and he said, "Oh, what are you coming into town for?" So I share what we're here for, and he goes, "Wow, hospital pricing. What a wicked web that must be." And I was like, wicked web, that is actually a pretty fair description, especially to the end consumer, right? There's a lot of confusion around how does hospital pricing work, their experience with it, what it means to them, which is why we are in the place that we are with pricing transparency requirements, right? So CMS recognized this feels like a wicked web to a lot of consumers. How do we try to address that? How do we try to make these things more clear? Now, the challenge that a lot of us have had, right, is some of the requirements that were put forth in many ways kind of made the wicked web feel worse. The requirements didn't always help to address communicating the information in a really effective way. And so they've evolved. These requirements have evolved, and in fact, there's some fairly important kind of changes that are being proposed right now that could be in effect as early as January 1st of this year. So we kind of want to talk about the requirements as they exist now, and then also some of those key proposals, all so that we can try to make sure that we unwind this wicked web. So there are two different types of disclosures currently. And I'm not going to spend a ton of time here. I'm guessing that many of you are familiar with the two types of requirements. There's a comprehensive machine-readable file for pricing transparency, and then there is a consumer-friendly shoppable services component. So CMS has recognized that there's kind of two different audiences with these disclosures. The machine-readable file is intended to kind of be for developers, researchers to bring this information down, try to develop tools and resources for patients to be able to access. The consumer-friendly shoppable services component was absolutely intended to make sure that consumers had access to easy to understand information. And they've given two options there. One is a file that a hospital can produce. The other is a web-based patient estimation tool. And by far and away, what we see people using here is that web-based tool, which probably makes it much more user-friendly in the end as well. The only other comment that I'll make here, unless there's questions, is that to date, CMS has really focused on compliance with that machine-readable file. So of any of the communication or letters or warnings that we've been made aware of, it's all involved that machine-readable file. Not at all with this consumer-friendly shoppable services component. We do see language and movement occurring that would suggest that they are going to be much more involved in looking at compliance in this area as well. So just a note, if it's kind of been a little bit before, since you've looked at that consumer-friendly kind of component, might be good to sort of just take a peek and make sure that that piece is up to date and is in order, because we feel like they're actually going to probably make a concerted effort here in fiscal year 24 to address that. Want to spend just a minute looking at the types of charge that are inherent with these pricing transparency requirements. And we've put it in a matrix very intentionally because there are combinations of the elements that CMS has requested that really are not technically feasible. And CMS understands that. But a lot of the confusion that exists sometimes within produced machine-readable files or some of the organizations that are looking at those machine-readable files tend to revolve around this key issue that they're looking for information that is not technically feasible for a hospital to produce. So some of these consumer advocacy groups are looking at it and going, gosh, the hospital has not put forward this information. The hospital goes, we don't have that information. Like it really does not exist. So what are those elements? There are 5 different types of standard charge that CMS has required. The first is gross charge. This is probably the one that all of us have recognized for years is kind of the standard charge. It's that CDM type of charge that we produce. The second is a discounted cash price. Some facilities don't have discount cash pricing, and that's okay. CMS recognizes you don't have to, so if your facility has not established that, it is not a requirement. That's a very key thing to understand. Some of these advocacy groups that are looking at this data expect you to have it, so if you found that maybe from a patient rights advocate that they've given you a non-compliance score, they may have marked a box that says you don't have discount cash price. You don't have to. And it's probably why CMS has not issued you a letter. The next 3 are the lightning rod. These are the ones several years ago all of us were sort of kind of concerned about. What do these payer-specific negotiated charges mean in terms of disclosing? This is your payer-specific rates, the rates and terms that have been established. But where this becomes sort of an issue is as we start to think about the types of what CMS calls items, services, and service packages that they want to see this data compiled in. So across the top of our matrix, we have the hospital and technical components for items and services and service packages, and we have professional services. And then we're kind of down on the other side of the matrix looking at those 5 types of charge. And what we see is, right, that the CDM is really only at a service level, right? It's a per unit level. So we're not going to create a service package charge that we store anywhere. It doesn't exist. Conversely, as we kind of walk down into those payer-specific negotiated charges, we don't develop per unit at the CDM level per unit payment rates. And yet some files are trying to be put together that would try to derive figures that way. But the challenge with that, right, is a patient will never have a payment at that per unit derived value. Payment is always fundamentally at a claim level. And that's one big piece that we have really kept coming back to with CMS in these discussions, and you'll see a field here that's being proposed this year that we're really encouraged by because it's CMS's recognition that payment is not at a per unit line level. It is always, always, always at a claim level. And so that's one of, again, the encouraging things that we see actually in the revised kind of proposals for this year. So all to say, some of these pieces, not technically possible. CMS gets that and expects your file to be put together in the areas in which you are able to produce a value. That doesn't always, though, translate well with those advocacy groups. So what are the proposals? What are the changes that are being put out there for this year? It really falls down into 2 different categories. One is modifying the current transparency requirements, and the second is around enforcement activities. Let's talk a little bit about those kind of current requirements. The first is CMS is going to or proposes to have an attestation on your file that says we believe that the information that we have put forward is true and accurate. Hopefully, everybody that's been putting their information forward so far would believe with that statement. So this is not sort of a groundbreaking addition to the file, But what that does is it actually helps them address concerns from advocacy groups that are saying these hospitals are just putting out junk. Like, they're doing it, no one's paying any attention, they're doing it with little effort, it's complete junk. This gives CMS the ability to say, no, like, this is a certified document, hospital leadership have agreed to these being true and accurate. So in the end, I think it's actually a win for hospitals to be able to actually say, yes, we've put this file together in a way that we believe is true and accurate. The second really is around standardizing the machine-readable files content through a template. One of the things that we've seen for years, right, is that you can put this file together really however you would like to put it together. That's created a lot of challenges for developers, who was a key audience for CMS, to kind of download that content and to create kind of meaningful information out of it. They are moving now to a template. So last year, they released a voluntary sample format in November of 22, and this year, they're now proposing to make that voluntary format a required format. There are a couple notable changes in that format. The first is, before they gave us several different methods to display the data, now there are essentially two. You can have a JSON file format, or you can have a CSV format. And those are the only two types of electronic files that they will now permit. In the CSV, there's a tall version where payers are going to report on or kind of repeat on rows. And there's a wide version where that payer data will go in additional columns. Most folks are moving towards that JSON file format, but if you're more comfortable with CSV, certainly that will be an option for you as well. And that was why they actually decided to go with those two different options. There are two notable additional data elements, and these are really important to kind of recognize. The first is drug unit and type of measurement. What they are looking for here is how many units typically go into that line and what type of unit that actually equates to. So is it 10 mLs, 50 mLs, and how many units would actually go into a typical dosage for that? This is proposed. All of this is proposed right now. The commenting window actually ended just a few weeks ago. We have out on our website, not that you'll want to read through all of it, but there's 14 pages of our firm's breakdown of these rules and our comment back to CMS. This is one area that we comment back to CMS that we felt was going to be especially challenging for hospitals. When we get involved in detailed pharmacy studies, one of the things that we recognize is many hospitals don't store this drug unit and type of measurement in an easily accessible database. So to draw that out, and I know we've got some critical access hospitals here, this would represent a very, very significant burden to actually have this. Many people are leveraging kind of a HCPCS description for that information, but think of all the thousands of lines that are in your pharmacy CDM to actually try to go through and pull out that unit and that type of measurement is really an unreal task. And again, many folks would probably be trying to do that manually, which would represent a very significant hurdle. So this is a piece that we really pushed back on, and we advocated, if they wanted to do that, to make the field optional and then have a requirement later in time where some tools and resources could be developed for hospitals to try to comply with this piece. The other is a contracting method and consumer-friendly expected allowed amount. These we are actually encouraged by. This consumer-friendly expected allowed amount is a recognition that payment does not happen at a per unit sort of line level. It occurs at a claim level. So what CMS is saying is, hey, if you're contracting with a payer and it doesn't fall neatly into just a per diem, just a case rate, just a percentage charge, we're going to allow you to select in your contracting method a field called algorithm, which basically suggests that it's a combination of these elements. To us, all hospital payment is an algorithm. Even if it's a percentage charge contract, there are conditions that sometimes supersede those different elements. And so our comment back to CMS was, we are unaware really of a contract that is not an algorithm. Every claim gets processed, it goes through, and based on the conditions that exist for that payer, a payment is produced. In spring of last year, we were asked to kind of present to a panel, and this was a key thing that we presented on, that the requirements as it exists today make it difficult for a hospital to comply with the rule, because displaying hundreds, if not thousands, of individual payer logic is an unreal task. The claim needs to be processed through, and a median payment needs to be provided on that service. And that's exactly what they're proposing here. So we were really encouraged by this. We think that it really actually promotes a better way for hospitals to be able to comply with the rule, and honestly, in a way that we think is the only way to comply with the rule. So keep an eye on that as it's released. Timing and enforcement, they wanted to produce all of this or have this go into effect by January 1st of this year with a 60-day grace period. We pushed back on this as well. The requirement right now is that these files get produced annually. We said if we think about it, right, like if you're a July 1st fiscal year begin or you're a January 1st fiscal year begin, by the time that final rule is released, which will probably be still in another month, that will give hospitals, 30 days to try to reproduce a file, and that would be the second file that they would have to produce in one fiscal year, which we said people are allocating financial and manpower resources to this. That becomes a burden. So we're hopeful that they will delay to January 1st, 25, but keep an eye on that as well. There's some accessibility pieces of information that are there that are notable. I don't know that there's a huge hurdle there. A link on the bottom of your home page that would allow a direct access to your file. I think it probably makes a lot of sense. People are having difficulty finding those. In enforcement, the real quick hits here. On assessment activities, the biggest piece that we have concern around is CMS is proposing to give themselves assessment authorization, not just monitoring authorization, which would mean that they could request of you all of your managed care contracts to determine if you are submitting information in a compliant way. I saw the mouths go open. That was our reaction as well. That's a lot of data. It also, for lack of a professional word, I thought it felt icky that the government can sort of demand privately negotiated contracts that in many ways contain proprietary language over to them. So I don't think their intent is evil, if you will. I think they're trying to respond to these advocacy groups that are saying this information we believe is not valid. But our comment back was, if you're adding in an attestation to the file, and if you believe that it is invalid, there is a method right now to work through a compliance kind of format. So keep it as is. If you've got a concern, raise the concern to the hospital and allow the hospital just to have a way to be able to communicate verbally on that, as opposed to turning over those documents. So that's a big one. System noncompliance, if you're a part of a health system, they want to basically just be able to say, hey, we found an issue with this file. Let's just take care of all of them right now and either clear all of them, because we're probably recognizing that you produced it in a similar way. We actually think this is probably a win. It creates less uncertainty for the health system to say, we know this one hospital is okay now, but are they going to come at us for the others? It sort of addresses all of that at once. The last is publicizing compliance and actions and outcomes. They would like to be able to, on their website, say when they have issued you a letter. We pushed back on this because in the rule they have said that they sent out 906 warning letters to hospitals. And upon further discussion with the hospital and further investigation of the file, they actually found that 301 of those were completely compliant. It was just a misunderstanding. It went away. So our comment back was, if a third of the hospitals that were issued warning letters were found to be actually in compliance, think of the downside media effect that would happen for those hospitals that would be posted on a website when there was nothing wrong that they had done. And so we said, hey, let's rethink kind of how this gets communicated and not assume guilt from the beginning, and basically just have a compliant, non-compliant action after the hospital has completely gone through the process. So we'll see how that works out. All right. Any questions on any of those things? Yeah.
Since this has come around in the past few years, and obviously there's been grace period and grace period, have any hospitals been taken to the point of actual penalization?
Yeah, there's 4 that have received fines to date. Out of those, again, 600 that had letters and were also deemed to kind of be non-compliant, but they work through that compliance process. The conversations that we've had really so far have really been good. I mean, I will say, I feel like CMS is really trying to just get to a compliant point with hospitals, but not be heavy-handed. Those facilities that receive fines truly just said, we don't care. We are not putting out a file. We're not displaying our payer negotiated rates. Case closed, we'll pay the fine. And if you're going to do that, you're going to pay a fine. So
That's 4 nationwide.
yes, yeah, across the entire country. Yeah, great question. Yeah, Shannon.
Do you have any updates? Do you have any updates on the payers? What's going on with them? Because what I'm hearing is they're not going to be held accountable.
Oh gosh, great question there. So, I mean, I could probably go on and on. I will try to be very quick. The payer files, while I will say they are becoming better, are a complete train wreck. Of course. However, I will say this. I don't think it is to their fault. The requirements that were set up in terms of their template is horrific, and their template did not come from them. So they are, if you try to download it, it probably crashed your system. They're impossible. Our firm had to actually have conversation with Microsoft Azure to open up a massive window to be able to actually download it and digest files. And Microsoft actually said, why on earth do you need this much processing capacity? And we said, this is the reason why. These are the files that we're trying to get. They're like, these files are unreal. We're like, tell us about it. Yes, we agree. So to get them and bring them down is unreal. And once you do, the challenge is, we've tried to compare the payer rates that we have from the hospitals that we work with. We don't see right now a connection to, in many cases, the actual rates that are being put forward, but it is improving. So I think it's just going to take more and more exposure, but we still don't see the type of press that's occurring for hospitals that's, I mean, nowhere. Yeah.
Well, I'm sure probably they're publishing file. I could see them publishing like the contracted rate, but not the realized rate.
That's right.
Which is.
And we really can't make heads or tails of it. In some cases, even with the same payer, so for United, for instance, there will be cases where it does look like it aligns to a rate that we have from a contract that we have. But for that same hospital, we can also look, and we're like, we have no idea, how did they even get this value then? Which actually then becomes troubling for another reason of, is that the information that they have built out for that hospital? Because it doesn't align with the actual contract that we can visibly see, the rates and terms that we see for that hospital. So is that what's in their system? That's another troubling piece. Yeah, great question. Yeah.
So Thank you. So how do you draw the parallel with the MRF format and FHIR format? That's question number one. I was very happy to hear that how you are looking at taking all that data and working with Microsoft, and how the AI, if being into the Microsoft cloud, which is one of the most secure cloud,
Yeah.
how do you see the Microsoft OpenAI is going to help sorting some of the anomalies and some of the very critical problems that you're talking today?
Yeah, this is a fantastic question. I think several of us that have been trying to work with the payer files believe that it probably is evolutionary, that it's not revolutionary. It's going to take iterations. It's going to be people holding kind of feet to the fire for the payers to say this data it does not look right. And as more people are seeing it, we think that it will improve, but it's probably not an overnight thing. It probably is it's going to take a couple years. We've tried to put some information together. We're not selling that because we don't believe that it's accurate. I know that there is some that is trying to be sold right now. Again, I don't see a reasonable way to be digesting it right now. Again, whether you're looking at it internally or whether you're trying to kind of work with somebody to draw down that data to do it, based on what we're seeing with hospital contracts that we have, I don't see that it's consistently being reported.
So do you mean to say that you have to make a change into the input where the receiving of that data is happening? Because if your data is not going to solve some of those problems, something input, garbage in, garbage out.
Yeah.
What is that process that you are thinking or change, that evolutionary or revolutionary, to happen?
So what we proposed back to CMS in this, actually just this latest round, was their last comment in the proposed rule was, there's all this information that's getting out there now. How do we connect the dots? And our comment back was, the only way to connect the dots is if everybody is actually assembling the information in the same way. To us, that becomes that consumer-friendly expected allowed amount. Everybody runs, the payer runs that claim through, the hospital runs that claim through, and determines what should be expected to be paid for that claim. That's where we should be aligning on. It shouldn't be, here's a list of 1,000 different codes and their fee schedule for these lab rates. Well, that's not the rate that's going to end up being paid. It's going to be combined in with a surgery that they had or anything else. So we need to sort of agree on the common point, and to us, the only common point that exists is the claim. So let's run it through. We're encouraged that CMS has that for the hospitals, but our point back was, now make the payers do that same field and put that field out there, because that should dramatically reduce the file size, and that should allow us to be able to actually have a window into what they're reporting. So we'll see if that takes place, but we think that's the only way to actually create that alignment. Yeah, great question. All right, I'm going to fly through a couple other slides here so that we can turn it over. It's funny, I told Monica I'll start probably 15, 20 minutes. So I want to make sure we get in. So with that, who is looking at this data? There's some really interesting points, and there's this one juicy topic that I love getting in rooms like this. So, because there's not a whole lot that's juicy in hospital finance, let's be honest. This one is. So media is looking at this, right? The two, actually the one largest is Wall Street Journal. Lots of reports have come out in Wall Street Journal on this. And I like reading the Wall Street Journal, but many of them are not fair. Like they are not educated views into how hospital charge and payment works. The other, as recent as this year, this has NBC Nightly News, and seated on the right is Cynthia Fisher. That's the face of Patient Rights Advocate. So if you've been wondering who is this person that's funding this and putting all this together, this is her, and that's where I'll get juicy in just a second. Researchers are looking at this, and in some places, right, like actually not making unfair statements, saying we're having a difficult time trying to piece this information together because hospital A and hospital B, it's really tough to make comparisons. We agree. Again, there's no common field that basically would connect dots, so that makes complete sense. Here's the biggest group, and they have been a thorn in the side of the hospital industry now for several years. This patient rights advocate, there's Power to the Patients, both of them are combined. They've put ads on before like the Grammys or the other popular shows. I'm like not really good on some of this pop culture references, but Susan Sarandon's been in these public service announcements and all of this. So the report that they are putting out is complete garbage. AHA, if you're trying to kind of work with a media response, AHA has a beautiful statement that's out there on patient rights advocate. That's, again, not a Jamie Cleverley saying it. It's American Hospital Association. It's a very well-written statement that basically says this is garbage and it's an attack on the hospital industry. Not a problem that someone wants to look for compliance. The way that they're looking at it is unbelievably, horrifically flawed. Why are they doing this? It absolutely feels like a personal vendetta against the hospital industry, and here's the juicy part. So, Cynthia Fisher is a multimillionaire and is married to, does anybody know? This is a very interesting reference. This is like the People magazine kind of stuff. She's married to the founder of the Boston Beer Company, who, if you go out and sort of do some research for, big political kind of fundraiser, and was instrumental in creating the hospital price transparency requirements in the Trump administration. Had wanted that to be the Trump administration's key healthcare policy win. In putting that together, because she was so personally involved in that, she has made it her personal mission to make sure that hospitals are complying with that. And if you're wondering, gosh, why does this keep happening? If you're a multimillionaire, and she is personally, and you're married to a multi-billionaire, you've got a lot of time and you've got a lot of resources to make sure this happens. So it's why you can get Susan Sarandon to appear in a public service announcement. That's been fascinating to me because I've been asking myself this question, who is this woman and why does she keep kind of coming after it? There's the why behind it. So CMS though, I love this. Yes, question.
As you continue to dig into her past, find out why. Why is she so excited about it?
So
what happened to her?
I do think that legitimately, it's not an evil place. I think it's a misdirected understanding or misguided understanding. I truly do. Again, it goes back to the guy on the plane, right? Man, hospital pricing, that's got to be a wicked web. She sees that too. She's got resources to say, enough's enough, we're changing it. Which again, I think all of us in this room would say we get hospital pricing is not at a place that we would love for it to be. But the implications to unwind it, and that's the next piece up, are very far-reaching. We didn't get here overnight. To unwind it overnight is unrealistic. So the requirement's good. I think it's helped push us as an industry to kind of rethink and evaluate how we do this. But this is where I wish that we could have almost a one-on-one conversation with her, because I don't think just fundamentally she understands the complexities behind the hospital billing environment. So CMS, I love this, came out this year. It was a week after a patient rights advocate said, hey, we only find about 24% of hospitals are complying. CMS in Health Affairs, a much more peer-reviewed journal, right, says, actually it's more like 70%. And here's the data behind it. Loved it. It was wonderful. So why are the differences? I won't go through kind of in detail here, but I want to point out a couple highlights. One is, because you might be dealing with media, we've worked with a lot of hospitals. They're like, how do we get back at this? Because the newspaper is saying we're not compliant here for one of these reasons, and it's one of these three typically. So we put some talking points down there to kind of help with communicating back. The first is they say, hey, 48.8% of the hospitals didn't publish all of their payer-specific plans. Key piece to note, they don't understand that if you put one Aetna plan out there, that one set of Aetna rates probably are the only Aetna rates that you have. They want to see Aetna PPO, Aetna HMO. In many cases, the hospital doesn't have separately negotiated rates for those products, or might not for each payer. They expect to see that. So any place they don't, they just assume that you've hit it. This next one really, really, really gets me. 46.2% of the hospitals did not publish a sufficient amount of negotiated rates. There is zero sufficiency requirement in CMS's rules, because CMS gets, right, going back to that matrix, there are plenty of places where those combinations will not result in a value. They look and they just say it's not sufficient. The thing that I love, if you read their detail, you will not see anywhere where they describe what sufficiency is and how they're evaluating it. So it almost looks like it's an eye of the beholder. And the last thing that I'll say on this is, because we talked about the discounted cash price already, is this. The group that they have held out, and I don't want to sort of like knock a hospital, but I will for the sake of what they're trying to do. They held up I'm from Ohio, held up in our Ohio legislature one facility that they said, this facility knocks it out of the park. They are best practice. It's an amazing file. I want you to look at this. That hospital published the same information for all of their payers that equated to their gross charge. So they said our gross charge for this HCPCS code is $1,000. And in every other cell for all of their payers, $1,000, $1,000, $1,000, $1,000. I'm like, are you kidding me? And this is who they are saying is the best hospital in the country. Incidentally, that hospital has reached out to find out if they can revise their file. We were kind of laughing at it. We're like, I can see why. They're like, we didn't expect to get all this national attention. We didn't really want the attention, and now we've gotten it. So, yeah, kind of fun. But all to say, this is changing. And I think that's where I'm going to try and transition it over. We've talked about some of these remaining slides and pieces. So, Monica, I'm going to turn it over to you so we can get into some good information on case study.
All right.
Is this on? Okay. Oh, Jamie's not done. He'll come back. And I have to use the microphone. Jamie, if you noticed, didn't need the microphone. So for those of you who don't know me or Providence, we have 54 hospitals, primarily in the western United States. So Alaska, Washington, Oregon, Montana, California, and Texas, New Mexico. So of those 54, we have 10 CAHs, critical access hospitals. So we have a mix. Oh, you have it. Okay. Next one, yeah. So I'm going to talk a little bit about the pathway that we've taken to manage our CDM with transparency in mind. So I've been working with Jamie we were just talking about this a long time. And it's funny that we've only actually met each other this year. And it's been through HFMA events. So thank you, HFMA. But it's funny that we've been working together for 15 years. And before that, I think even your dad. So, and we've only met each other this year. So we, on our journey, we took 3 main steps. So we'll go over them in detail. And hopefully I'll remember stuff. Jamie doesn't need notes, but I need notes and glasses. So the first thing of the 3, we're establishing the team and process, creating defensible policies, and then standard and simplifying structures. And that's probably going to take the most time to talk about because it's a long road. Okay. So the first was establishing the team and process. So if you don't already have a team, our recommendation is to get one. And I was talking to Jamie about this. I mean, when we first started, it was a team of 3. Me, someone from finance, and someone from Cleverley. It's gotten a little bigger now, and it's a little better. But if you don't have a team, start with your project team. So that's going to be usually your charge master or your CDM, revenue integrity leader, someone from your corporate finance or your finance department. And then if you're working with Cleverley or another vendor, that's your vendor partner. It wasn't until after the 2019 final regs that Providence then also developed a steering committee for pricing transparency. And that actually was at a higher level. So we brought in senior leadership from all sorts of different areas, thankfully. So that included legal counsel, advocacy, your web team, your Epic IS, finance, more people from finance, marketing and communications. Because you can see from what Jamie just went over, it's a whole different ballgame now, right? Everything's much more public. Everything has to be much more transparent. So that steering committee has also helped make recommendations to our senior leadership on, what we're publishing, when we publish it, how we're going to respond to the comment period and things like that. So one of the first things that we recommend is make pricing review a requirement. So, you think that would be obvious, or especially in this day and age, but you'd be surprised. So when I first joined Providence, it wasn't a requirement. It was an option to review your pricing annually. So we made it a requirement for all of our hospitals to look at their prices every year. And we would recommend aligning that with your normal fiscal year and budget process, whether you do it before your budget or after your budgets. There's pros and cons to both of those approaches. Most folks, I would guess, are doing it before their budget finalizations. So the other key thing that we noticed or that we would recommend is limiting mid-year price adjustments. So this was big for a health system our size, because historically we had allowed all the clinical departments to actually submit price changes throughout the year. And that makes it very difficult when you see all these new requirements that we have to abide by. And we're trying to do this annual pricing engagement with Cleverley, and it just doesn't work if you have all your clinical departments trying to submit mid-year price adjustments. So we definitely limit that. And by mid-year, I mean some of the exclusions which we would allow to happen are obviously if you're starting a new service line, you're starting a new department, you have a deployment onto Epic obviously going on. There are some things that you would definitely would accept as a mid-year price adjustment. But anything else needs to go through the CFO, and I'm smiling at Marie over there, and would be incorporated into the annual process. So the feedback from the clinical departments is still valuable and is still used, but we just incorporate it into the annual process, and it doesn't happen outside of that process. So the next step was creating defensible policies. So this is surprising because as I was talking to Jamie, he said, you'd be surprised how many health systems or hospitals actually don't have a policy in place about pricing or defensible pricing. And I'm not surprised because it was hard for us to actually create a policy and get one in place. But you can start small. Focus on compliance and establish guardrails. If you think about it, most of the people on your project team or your CFOs don't necessarily know all the details, even the information about that Cleverley just gave, Jamie just gave, but they don't know all the details about CMS billing compliance, the really minutia, and also the details about your organization standards. So putting a policy in place actually helps set some guardrails, so the whole project team knows where they're going. Let's see. So hold on, let me see. I know I'm forgetting something. Okay, so starting points, forgot to tell you what to include in there. Starting points to include in your policy. Obviously, the obvious is to actually have annual pricing review, right? The intent is that our hospital or our health system actually reviews pricing annually. Things like The prices will be developed on a variety of factors, your costs, market factors, and things like that. And it'll also list, like, the pricing team consists of who, right? Who's going to be on your pricing team? Who's making the final decision on prices? And usually that's going to be the hospital CFOs in conjunction with corporate finance or a finance leader. So some of the other things that we put in the policy were the procedures that actually align with the policy itself. And so a lot of these will tie back to CMS billing compliance and CMS guidance. So some of the very obvious things to put in your policies are things like same price for all patients, right? Hospitals charge the same price for all patients regardless of payer. But you'd be surprised at how many payers don't realize that we actually live up to that requirement. So we've had several payers come back to us thinking that we actually charge differently by payer. CPT consistency. Where possible, charge the same price for the same CPT across all your service lines, right? That's something that over time your system might have been developed or your departments might have been loaded at different times. And so you'll see sometimes there's some inconsistencies there. Acuity, and this is something that our analysis with Cleverley really helps with, is making sure that your prices are set so that higher level acuity services are actually priced higher than the ones that are lower level acuity. Another key thing to put in your policy or your procedures are volume. In the old days, or historically, sometimes you only adjusted your annual pricing based on the charges that actually had utilization on them, right, or volume. And then the next year you noticed, you wondered why your pricing was all out of sync. So, make sure you actually look at every charge every year or the price on every charge every year as part of your analysis, not just the ones with volume. So putting that in your procedures is that one of the things that's going to support your policy. Also, admission status. Admission status will not be, or for us, is not the sole method for determining price variation. So an inpatient versus an outpatient is not just the sole determinant of what that price is. Wherever possible, dynamic pricing. So that is for pharmacy and supplies. So wherever possible, try to link your pricing to the actual costs from your item master for supplies and your drug dictionary for drugs. Sometimes in smaller hospitals that's hard or difficult to do, but if you're a larger hospital or health system, definitely put that as one of your goals, is to make your pricing dynamic. That ensures that your patients are actually getting charged based on the actual item cost for that actual date of service. It also limits the maintenance that you have to do in updating those prices manually. Let's see. Oh, this was a surprising one. We put it in after we discovered that for some reason we had some gaps. That if you have a supply markup policy, make sure that all the departments in your hospital actually use or follow that policy. So we actually have standard supply markups at each hospital, and we found just some outliers where some departments had decided to add some supplies to their charge master, and over the years they had just decided to set their own prices. And so just cleaning that up was, putting that in our processes was important. So using a single hospital supply markup that's applied across all departments. And finally, just even setting up a methodology for your hospital to add new CPTs during the year, to price the CPTs that are added during the year, just to reduce the burden on having to go back to the CFOs or do an analysis. So we just use a % markup over APC. So that actually makes it easier for us to get those prices in to the charge master during the year, but also to set a standard methodology across the health system. Next. Okay, so standardize and simplify structures. So there are 3 areas of CDM work that actually lean into transparency. So it's very hard to do some of the things that Jamie was talking about if you have some issues in your charge master. And this is a kind of a discussion on the road that we've been on at Providence. We have 54 hospitals that were deployed on Epic originally across 5 different instances over 10 years. So we had a lot of variation to clean up. So first is what we're calling this charge standardization, but for lack of a better term, but it encompasses several things. So the first is consistent charge methodology. And what do I mean by methodology? That is the actual method that you're using to charge from their clinical application that then generates a charge and a price on the patient's bill. So labor and delivery was interesting. When we started looking at this, we realized that we didn't have a standard vaginal or C-section case rate across all the hospitals. So first year we tackled creating a standard vaginal case rate, working with our Epic clinical application teams for Stork. And then the following year, we worked on the C-section case rate, working with our Epic application teams for Optime. And that went down to the documentation level, like what is going to be included in the case rate, how does that supported by the documentation in the clinical application, and then verifying that that's actually what's generated on the account. So developing these consistent methodologies across your hospital also allows your hospital or health system to do analytics across hospitals. So if you don't have a standard methodology across each hospital, it's very hard for anybody to do comparisons on, productivity, costs, charges, anything like that. So the second was supplies. Like I said, we worked on our supply methodology, and this was something that we worked with Cleverley on when we first started. Over the years, all the hospitals had developed their own supply markup methodologies, meaning some folks were using just a flat rate, some people had different bands, some people had 3 bands, some people had 50. So we developed a standard 22-tiered declining markup methodology, so that with consistent banding, cost bands, so that all of our hospitals use the same strategy. Obviously, the percentage markups are different by region, but at least everybody's using the same methodology, and then that's automated. So that was an interesting project. And for that one, we actually pulled in folks from our supply chain onto the project team during that year so that they could help us and understand why it was so important that these linkages were there between our system and correct between Epic and our item master. Pharmacy, same thing. Over the years, we realized that we didn't have standardized drug categories, or the markup tables were different for those drug categories. So taking that on was also an interesting effort. And all of this requires a lot of analysis, right? So you're working with your vendor partner like Cleverley to do the gross and net revenue analysis for these projects to see what the impact is going to be. So with pharmacy, obviously we had to look at all of our drug dictionaries, all of the items in those drug dictionaries, make sure they're in the right classification, and this is where we're working with our pharmacy operations as well as our Willow team to make that happen.
Yeah.
Yeah.
So, is there a microphone?
Oh, Jamie's got one.
Thanks. So I'm just thinking about this, and there's a lot of complexity at Providence, but you also have like a lot of people. How would like a critical access hospital or anybody have this level of specificity and data analysis?
You'd actually be surprised at how small our project team actually is, right? We don't. Even though we have a lot of people at Providence, I mean, to get this work done, it's literally a very small group of people. I would say definitely engage the folks in those areas, because a lot of time you do have some experts in your supplies or your item master or your pharmacy to help with those efforts. Cleverley can also, we used them at some point, I think more in our supply process, because at the time we did this, we had not yet standardized our item master. So we had 3 different item masters with data. So sometimes we actually use them as a to assist us in aggregating the data or reviewing the data because it was such a large amount of data. And one of the things that a lot of our hospitals or CFOs don't have folks on their teams to do some of this analysis. I agree with you. We don't even have that bandwidth sometimes because even though they might have someone in the seat, they have a regular day job. And unfortunately, this has become a full-time project, right? A full-time endeavor is to do all of this work, but then all of the work that Cleverley's doing or that we're doing to meet the CMS requirements.
I think everybody's trying to do this. This came up in Oregon as well at their conference a couple weeks ago, and there's a lot of discussion on how to manage charge master.
The last one that we looked at was operating room minutes. So the other thing that was interesting is when we were looking at pricing transparency and part of, we had a question back there.
This is so amazing. I don't come from the healthcare background, but I come from the technology background. And when I see these kind of processes, a lot of things start coming into my mind as this is the process that you are setting as a best practices. Do you use any tool to make this happen so that your project team, your other leaders in the organization can create it and then execute that?
That's a good question. And right now, a lot of those tools are manual. So both of these are probably linked together as like, how are we going to do this? And how do you, as a small organization, develop this? Before I was at Providence, I was Legacy St. Joe's, and we had a smaller footprint. So yeah, it does start small. Like I said, our project team was 3 people, right? And it was 3 people up until only 2017, where maybe we got 5 people, right? I mean, so it wasn't this huge group of people. We have to pull in people from those other areas as we identified an issue, whether it's your IS partner or the supply chain partner or someone from IS who knows a little bit about bots. So it'll be interesting to see what AI and more of automation can do, because that's something that we are looking at is how can we, and I'll talk about that in a little bit, how can we make that a little easier? So anyway, back to operating room. Oh, I had a question.
Just a couple questions, one relating to the CDM overall and the other kind of to the industry. What you've said is traditionally what I think I've known since I've been in healthcare as far as the standards are what we're supposed to be doing. The difference has been kind of an overall strategy that we've been forced to employ, which is more about pricing based on ability to collect something back. So Medicare doesn't pay anymore because you increase their rates. So in the past, we may have seen differences, some prices higher than competitors, inconsistency, but it's been more focused on how do we make a dollar. Mm-hmm. And I'm curious, as far as with your work, what you've found, it's still true, I'm sure, mm-hmm. but have you had to address that head on, and what have you looked to do with that?
Yes. And so that is actually work that's ongoing. I mean, because the more visible you can make your pricing, so this work has made it more visible to the folks within our organization, right? So beforehand, the CFO of a certain region or a hospital would be knowledgeable about what's going on in their region, but they really didn't know how they compared, or it wasn't part of their focus to see how they compared with other regions within our home health system. So we're looking at that as a health system as far as how do we set our pricing, how do we make that transparent and more defensible. And yes, we need to look at what the net revenue impact is, because the reality is we have to get paid and we need to make sure that we're getting reimbursed. But where can we potentially revise our pricing so that it's more strategic or more defensible? So we are looking at that. I don't have any answers. I don't know. I'm trying to see, Jamie, do we have any? It's tricky.
I guess the other question maybe ties into it. For the industry, one of the challenges, I think, is that we are not I guess in this, where in the past we had employers that didn't have information, we now have employers that see information and they look to our Medicare pricing fee schedule as being the standard. And so there's an ongoing, well, that should be our price. And I'm curious, nationwide, I mean, a comment I think earlier was about that from Jamie, was that we did not, why are they doing it? I think it's pretty simple. Everybody wants to pay less, their insurance is costing more, and they're forcing the industry to say, we don't care.
Really good question, and maybe one comment there, because one of the areas that we get involved with at times is sort of like litigation, where there's a case where a certain group of patients is and sometimes being represented by a third party that didn't have a contract with the hospital to say, hey, we paid you 125% of Medicare, that should be sufficient. And the hospital's like, well, you don't have a contract with us, so you're paying 100% of charges. And the third party goes, no, that's unreasonable, we're not doing it, we'll just take what you want, or take what you get. And one of the things that we've found that has been helpful in those litigation cases is pointing out the deficiencies in governmental reimbursement programs. So, this isn't information that any of us develop. Medicare each year through MedPAC will say, hey, here's how much a Medicare patient, or essentially on the whole, is providing, and it's been running 7% less than cost for a hospital. And Medicaid is typically by state, but on average it's 25% less than cost. And so the comment back is, yes, we all understand that you may not want to pay this rate, but the reality is we have to, in order for the hospital to be viable, we actually have to have reimbursement from commercial payers that exceed Medicare and Medicaid, because we won't be in business if we don't. And then the question comes, well, how much then above Medicare is sufficient? And one of the things that we walk through is essentially to say, the hospital is budgeting for X volume to come from each of these payers in each of these categories. You've, third-party payer, disrupted that. We are completely happy to negotiate a contract with you, but you didn't. And in that case, payment is gross charge, and gross charge is 100%. And we have seen actually success with that almost universally, with that process. So,
do you see a process involving more, I guess, hospitals, clinics, et cetera? There are more bad insurance actors these days than I've ever seen.
Yeah.
We chase money on $2,000 accounts,
Right.
don't even have a place to get a hold of, and yet they pay what they pay, and we're constantly trying to figure out. So it's almost like we need a collective legislative solution to allow us to be able to do what they're asking us to do.
Brilliantly said. And you're right. I think that's what keeps a lot of hospitals from actually even pursuing it. Is it's like, gosh, okay, yeah, I'm getting paid $5,000 less on this one account, but if I can't financially go after that, because it's going to end up in court, and I can't. My fees are going to well exceed $5,000. So you do this sort of cost-benefit analysis, and it tends to be more class action, where we're getting involved, where it's representing very large segments of patients that are trying to kind of reimburse on that method. So you're right. It's a horrible place, and I don't see that out there, but that would be an amazing thing, to actually have some type of a collective to go back. So that's really good.
It feels like we're approaching a point where we're going to have to be separating insurances into groups that pay and groups that are bad actors, and some sort of strategy that says to the patients, we're going to give you self-pay rates, and we're not going to take your insurance. Good luck in getting your money from your insurance. But it feels like there's too many of these payers that there's no contract, they don't care, and they don't contact.
Yeah. Yep.
Well, what we're seeing is that even if you do have a contract with a payer, they're not paying you either. And they're basically using a lot of those same arguments to you might have a contract. Well, we have contracts with payers where it's not based on Medicare allowable. And yet all of our denials are coming through that we're not going to allow those charges to be on that part of that reimbursement calculation because it's not a Medicare allowable charge. And we're like, well, our contract has nothing to do with Medicare allowable, so why are you sending us this denial? So that's been an interesting increase over the last 2 years. So definitely taking a more aggressive stance at Providence than we previously did for that same reason is, do you fight the small number of claims, and then when it becomes this large number of denials, you have to, start to draw a line in the sand with the payers. So some of the CDM work actually helps with that because it's more defensible when you actually can show that you are a standard in your approach, right? So like I was talking about before, the last slide, one more item, which was OR minutes. So when I started, we had 4 different ways of charging for OR minutes at Providence. No reason for that. It's just when they were brought onto our Epic system, they were just deployed with whatever the mechanism they were using in the past. And so basically standardizing that so we all charge the same, making sure that comes from the Optime or whatever system you're using, EMR, so that it comes through consistently and is based on the same factors. So that allows your system to look at things across service lines or across hospitals to compare productivity, operating throughput, and things like that. When we first did this, productivity department was so excited because they were like, do you know how much work we were doing to try and figure out, how many minutes and how many cases were going on when you had 4 different ways of doing it. So, there's some definitely standardizing your charge master not only leans into transparency, but it also is an enabler for advanced analytics. Because like we were talking about earlier, you don't have a lot of people in your facility to sit there just to normalize the data, let alone then do all the steps to analyze it. So if you can make it easier for your data team or your finance folks to just be able to intake the data and analyze it rather than try and figure out, what it all means. Okay, so where are we? Okay, simplify charge structures. So this was another, where possible, look for where you can simplify your charging structures. So, pulse ox is obvious because, you're only supposed to charge 1 of those per day, but you'd be amazed at what comes across. And so that itself was like, why are we getting all these denials for pulse ox that are on our claims that somehow made it in because, various departments were trying to charge for pulse ox more than once. So just aggregating that into a single item, making sure your system's locked down so that it's only hitting your patient account once per day. And then again, anesthesia and OR minutes. We did a lot of work, as you've heard me talk about, in this OR space because we had a lot of variability to clean up. There are some, how do we put this? There's some information out there that it's probably not the best idea to have or it's not supported to have a separate anesthesia facility minute. So we wanted to err on the side of caution. I also looked at, what were we including in our OR minutes, and we just consolidated all of our costs, including anesthesia facility costs, into a single OR minute. So we don't have a separate anesthesia minute and a separate OR minute. It's just a cleaner methodology. It's also easier for the patients to understand and also easier just to analyze and reduces any potential compliance issues related to charging a separate anesthesia minute. And then this is actually this is actually something that we're working on right now. We were working with Cleverley on a deployment that came into our system where we noticed they had a bunch of bedside supplies, and then we realized, what are these? What are these items that are coming through in this file that, we're going to be converting over into Epic? And we realized that we had a little gap or a little a hole in our process where departments were being allowed to just basically submit tickets to IS to have these supplies built in the clinical system so that they got added to an orderable. And so now I've got 10 years of ordables for our team to look through to see, what do we need to clean up, what do we need to remove, whether they're chargeable, whether they even meet our current standard supply policy. So that's just an example where, there's always a gap to be filled, and always somewhere that you can look at for the coming year. I do want to talk about that too in the next slide. So fee schedule review, because that's another thing that Jamie wanted me to talk about as well, is looking at your fee schedules for strategic fee schedule design, and consolidating any unnecessary fee schedules. For example, we had a region that had over 150 fee schedules or rate schedules. And that's usually comes from some historic old EMR build. So back in the day when every department had their own fee schedule. I don't know if you remember those days. So PT had a fee schedule, surgery had a fee schedule. And so some of those are still left behind in older, older builds. So we actually got rid of 87 fee schedules for this one region. So consolidating when necessary, because we found that you really only need your location fee schedule, an outpatient fee schedule, and then your client fee schedules. Also look at fee structure alignment for commodity services. So in certain areas, this can be supported and defensible. So creating a separate outpatient fee schedule for services like imaging, lab, surgery, and rehab therapies. And there's certain criteria and considerations of how you would do this so that it's defensible, meaning it's got a separate cost center, it's in a separate location, it usually has separate staffing. And so those are defensible and supportable for you to have a separate price structure for those. And these are areas that are mostly commodity services, highly shoppable, highly competitive, so where your hospital is competing with a standalone or a physician entity that started their own surgery center. So things like that where you're trying to compete in the market with a non-hospital entity. And it's hard when you only have your one main OR or your one lab fee schedule, right? So to think about that kind of strategic fee schedule design. So every year when we start our Cleverley engagements or our annual review process, we take a look at our fee schedules, all the ones that are out there, and make sure we understand which are being used for the main locations, which are outpatients and which are clients. This also drives how accurate your MRFs are for pricing transparency, because you want to make sure that you're communicating the right information to your vendor who's preparing this, or to the people on your team if you're not using a vendor. So you don't want to accidentally include client fee schedules if, on your MRF, or things that are not supposed to be included, like self-pay and other things like that. So the other thing that we do is part of our annual process is we actually set a list of what we call presets or freezes, so that we have a standard list across the enterprise, and we allow the hospitals to tell us each year has anything changed. So those are the things that we don't want Cleverley to touch. So those are usually your administrative stat, your penny charges. If you have state mandated pricing for newborn screens or genetic testing or things like that, vaccine programs where you have to submit a certain price, your cash pay rates. You don't want Cleverley or anybody, increasing those in error. Sometimes your blood pricing, if you're a Rev 390 hospital using a community blood bank, you don't necessarily adjust those every year. So that's also helpful to make sure that, things don't accidentally get increased and end up on your MRF with a strange, price on it on your website. Next slide. So that talked about a little bit of what we've done in the CDM, leaning into transparency, and there's a lot of, obviously, as Jamie told you, there's a lot more attention in this space, and so we're always looking at, what's next. So we were just talking earlier when we were preparing for this, it's like, we queue up what we're going to be working on for 2025. We'll start queuing that up in January 2024. So we actually work on pricing pretty much all year round. We meet weekly, our project team, to talk about just what are we going to have to, what's in the hopper as far as projects within our health system or hospitals, and how do we need to analyze that so that our pricing takes that into account. So whether that's deployments, mergers and acquisitions, new service lines, cleanup projects like what I was just talking about. So every year we start planning that agenda well in advance. And we were actually just talking about some things, maybe we need to go back and look at, these types of items. So you definitely start your list and start early so that you can work with your project team to try and get those, get the resources or start planning for that at the beginning of the year. Any questions?
Couple just quick notes to end then. So we've talked about the ongoing work that it takes. Now that this information is being public, we've got to be looking at it. We've got to be making sure that it makes sense, that it's out there and people can understand it. There's a few sort of just things to consider as you're looking at your current position and then forward thinking. And this is where we'll close. The first is just compliance, base compliance. We know, CMS said, that there are still 30% of hospitals that are out there that they do not see compliant. And if you're in that 30%, base level is trying to make sure that you've got your machine readable file, that you've got your consumer shoppable kind of piece out there and ready to go. Because we do see that kind of continue to ramp up.
So one of the things I forgot to mention is that the standardization work that we did do also helped us make those patient estimates more accurate, right? It was very difficult for our system, even Epic, to do patient estimates when you had such variability across all of these hospitals or regions. So that was definitely enabling work or prerequisite work that we needed to do to make sure those estimates were accurate as possible. We actually have a team now that actually looks at retrospectively how accurate was the estimate compared to what the patient ultimately was billed, so that we can try to learn where the gaps are in our system.
Yeah.
So is that improving?
Yes. Yes.
Where did it start and where are you at?
What do you mean?
How accurate were you when
Yeah, that was interesting. So we are actually, I'm trying to think if we're within a 15%. Cleverley doesn't do it, but I'm just trying to think of, but when we first started, it illuminated certain things like this, or where the system wasn't able to decipher, where the patient was actually going. Like if the patient was going into an outpatient surgery, it was accidentally pulling in all the main operating room utilization into that estimate. And so then to figure out why were we seeing such discrepancies. A lot of the discrepancy that's in the remaining 15% is when the patient doesn't have the same procedure that was initially scheduled. And that's just something that's going to happen, no matter what. But we were trying to plug those holes based on just system build or, just where the system wasn't working at a granular level to find those estimates. We still have disclaimer language out there because we know we have a lot of work to do, but it's a lot better than it was when we first started.
Do you guys feel like it helped you guys, like, from a revenue perspective, kind of narrow down, like, stuff that was like a variable cost, right? Like if you're doing budget projections, I guess, like, if you're standardizing things, do you guys feel like it's more beneficial budget-wise? Like you're able to kind of project out better? Or do you guys still see a lot of variability?
We were just talking about that. It is definitely allows the health system to look at their budgeting from a standard perspective. Because for a lot of these services, for example, drugs and supplies, our costs are the same across all of our entities. There might be some regional variations based on drug availability or things like that. But so then, knowing that, our CFOs can, look at strategically how they want to set those prices. And then even regionally where labor pricing might be similar, so, certain parts of Washington versus Oregon, then they can look at those the underlying cost and make some assumptions. And sometimes when we see that they're not aligned, okay, what's going on in that region or at those particular hospitals that's causing those costs to be out of alignment. So that was actually something that we were talking about of queuing up for next year because we want to look at that more globally.
you should try and exclude the stuff that's extra, like, you know, we were replacing your hip and we took out your gallbladder. But if it's related and it happens all the time, you should try and stick it in there. I don't know.
You mean in the estimate?
Yeah, in the estimate.
And also
I don't know
in your
if you're at
costing data, right?
I don't know if you're at that level of sophistication where you're looking at that 15% and trying to see, okay, which ones were gallbladders plus hip replacement and which ones were, you know,
I know they're looking at each one at the actual estimate level to see what opportunities, and sometimes it could be that we just don't have an Epic template built for that estimate, because, you know, this isn't like, you know, maybe that's something for the AI folks in the back, but we actually have to manually build these out based on the procedures so that Epic knows how to calculate these estimates. And so when we first started, when CMS first came out with these regs, Epic wasn't as prepared either. I mean, other EMRs probably were caught off guard, right? Where all of a sudden everybody's like, okay, I'd rather do the shoppable services or the patient estimates than have to publish, you know, the list. So in the beginning, it was a little limited in what we could do with those templates. So CDM was also involved with IS to develop those templates. Oh, yeah. Sorry. So, yeah.
I was just going to ask, how many years have you been doing this? Preparing.
Preparing for CMS, pricing transparency. Well, that's interesting because I came from Legacy St. Joe's and we had a large number of California hospitals. And so California had some form of pricing transparency dating back to 2005. So we were definitely looking at publishing our gross charges that long ago, right? So it was something that was within our but as far as when we first started for, say, this latest iteration from CMS, I'd say probably 2017, 2016.
Yeah. I think that's about right. Great discussion, and we'll hang after too, in case during the break, in case there's some continued conversation and questions. Two quick in 30 seconds ending points. One is to your question in terms of what's next. This is a view that we're increasingly being asked to sort of look at, and it just gets to that, and that is frequency of associated procedures, so the patient understands, if I'm coming in for an encounter, I recognize that encounter is going to be variable. So looking at what is the typical utilization of these associated procedures. So trying to point that out in the data has been really cool and interesting, and how that impacts payment. And the last thought is this. Oh, if I can get to it. Is it going? No. Oh, there you go. Okay. I always like to close with this thought, and that is, this all started in ACA back in 2010, and there was this very vague language around making your prices public and transparent. And all of us sort of sat on it a while going, I don't even know what that means. Like, what do they want to see here? In 2014, they reminded us, hey, you should be doing this. Try and get the information out there. Again, pretty vague. No one really sort of knew where it was supposed to go. In 2018, that's when we got our first, this is the way that we want to see it put out there. And I don't think this train stops unless we start thinking more of like this stuff, how we try to, you know, communicate information in an out-of-the-box way to help people, you know, looking at this stuff that's on this slide of like taking, and you heard Monica do a great job just walking through all the different stuff. When we start to think about our charge master, when we start to think about our payment structures, how do we simplify those? So it's all of that stuff. If we do that, I think we cut down on the government saying, well, now you got to do this, now you got to do that, because we're satisfying the need that exists in the market, and we get back to addressing the guy that said it's a wicked web. If we make it not a wicked web, man, oh man, we've done our job. So thanks for spending the time today to just walk through this. Great discussion. We appreciate you guys being so engaged. It makes it so much more enjoyable and fun. So we'll hang up here at the end in case there are questions, but thanks again.
Yeah, thank you.